Good afternoon, everybody. Collette here, and I'm with Dr. George Mells again for such a long time since we've spoken to each other. And welcome to our question session. As always, we'll be asking general questions. Dr. Mells, George, it's not fair to be asking questions that would, look like it was a personal consultation to you, because you couldn't possibly do that without having your file in front of them and complete information. These questions are for guidance and general knowledge only with PBC. So that keeps you safe, and it certainly keeps our medical advisors safe. George, how are you?
I'm very well, thank you, Collette. And how are you?
I'm good, thank you. I'm delighted to be back. Now, George, before we haven't got a lot of questions. Before we ask these questions, I've got a question that I would like to put to you, if I may. So I still do helpline calls for the foundation. And yesterday morning, I had 3 on the same subject. And all 3 were about sodoxyolic acid. For those out there, that's what we take when we've got BBC. And these people were having tummy troubles, all relatively new, within, months. They'd all been taking it weeks, months. And I asked which pharma company that they were getting the Ursula from. And they were all different ones. I'd never heard of them before. And I'm to understand from a chemist that the Ursula would be the same. It's the casing around the medication. It's the capsule that can vary in its content, is the chemicals within that. So I've asked them, as I've asked other people, it's been quite successful for people to ask for Ursula Folk, because it is the one that is licensed for PBC. I'm not sure the others are. That's the one that seems to help people more. What about, do you hear any of this in the clinic, George?
Yes. So I suppose my first question would be, have they just started it, or have they been on the sodoxyolic acid for ages?
From weeks to months was the spectrum.
Weeks to months, okay, so relatively new. I mean, diarrhea is quite a common side effect from sodoxyolic acid, irrespective of who's made it. It's not an unusual side effect, particularly when people first get onto it. It's common enough that when I prescribe it, I usually ask people to introduce it slowly.
Yeah.
So I suggest they take 1 for a month, and then 2 for a month or so. And some people say 1 for 2 weeks, 2 for 2 weeks, etc. And that sometimes helps a little bit, but there will still be a proportion of people who have diarrhea, whatever you try to do, whichever formulation you try to use, and those people will need to move on to second-line treatments. So I guess for these people, a couple of considerations. I mean, if they have only recently started the sodoxyolic acid, it might be worthwhile chatting with their clinician to see whether they should stop it for a brief period and see what happens, and then reintroduce it more gradually. That would be one option. If they've been taking it for a long period of time, it could be down to the formulation, as you were suggesting. They might have tolerated one formulation, but they're not tolerating the next formulation. And then it's a case of either reverting to the one that was tolerated, or ringing the changes, and the pharmacist can help with that. Or it could be that it's dose related. So it could be that actually they can tolerate a slightly lower dose, but not the maximum dose that they want to be on. And if they can't tolerate a top dose, that's not necessarily a disaster, provided the liver tests are normal on a lower dose. If they're normal on a lower dose, then that's okay.
That's fine, yeah.
If they're not normal on a lower dose, then again, you're starting to think about second-line treatments.
Yeah. Okay. I thought it was worth mentioning. So it's 3 in 1 morning, and there's a story I hear very regularly.
And sorry, Collette, one other thought. Sorry, just to actually, and I should have really emphasized this at the very, very start, was that above a certain age, any change in bowel habit needs to be taken seriously. So, so if this is a case of a person's been on their urso for a long period of time, they've been absolutely fine, but for the last 3 weeks, 4 weeks, they've had diarrhea, actually they need to report that as quickly as possible to their GP, just to think about other potential causes for that.
Okay, that's helpful to know. Thank you, George. Okay, so I'm going to start with the questions. Some of these words I can't pronounce, and I'm not going to try. I haven't tried in the past and failed and made myself look sillier than what I am. So somebody's, how common is non-cirrhotic portal hypertension in patients with PBC, and what may be the cause of this, as normally it is associated with cirrhosis?
Yeah, so I suppose we should just step back ever so slightly and define some terms. So when we say cirrhosis, we mean severe scarring of the liver. And a consequence of having cirrhosis or having severe scarring of the liver is that people can develop portal hypertension, and that simply means increased blood pressure inside the portal vein. And just to take an even further step back, the portal vein drains blood from the intestines into the liver. That blood then has to pass through the liver to get into the rest of the circulation. So if you've got a badly scarred liver, it can be quite difficult to push that blood through the liver, and therefore the blood pressure in that portal vein goes up. And the reason it's important is because if you have portal hypertension, you can develop varices, which are swollen veins, often found in the esophagus or in the stomach, and those can bleed. So that's the sort of the background and practical significance to that question. Now, it is possible in PBC actually to develop portal hypertension, increased blood pressure in the portal vein, and to develop varices without cirrhosis. That is well known. I had to look up,
how common is that?
Yeah, well, I had to look that up actually because I couldn't think of the figure offhand. And there's not too many publications on this, but the figure was anything between 5 and 30% of people who do not have cirrhosis can have portal hypertension.
Right.
So I guess that means it's not uncommon.
Yeah.
If it's between 10 and 30%. And that's important, of course, because what it means is that your clinician needs to keep an eye out for that. Fortunately, there's a reasonably simple way to keep an eye out for portal hypertension, which is to keep an eye on the platelet count.
All right, okay.
People with portal hypertension, their platelet count tends to fall and will often be slightly low. So if you know that the person doesn't have portal hypertension, doesn't have cirrhosis, but you spot that the platelet count is falling,
further investigation.
Then further investigations, exactly, to see whether this could be a case of the non-cirrhotic portal hypertension. In terms of why does it happen, well, that's not entirely clear. There are various theories that perhaps PBC leads to some damage to the very tiny little blood vessels inside the liver, and that affects the portal blood flow. But the exact explanation is not entirely certain.
Okay. Thank you. So this person was recently in hospital with severe kidney disease and was given gentamicin, gentamicin. One outcome that a month later is still suffering from dizziness. It's improving slowly, but the GP has prescribed procloroparine to help.
Yeah, that's Bucostem. So many people will know it.
It's quite interesting. This person says, the leaflet says to take care if you have liver problems. Is it safe to take the PBC's question? I laugh at this sometimes because having come from the legal profession, that's legal belt and braces. I think everything says that about liver disease, isn't it?
That is true. That is true, actually. So, I mean, the simple answer to that question is that probably yes. I mean, PBC for sure is a liver disease, but actually not everyone with PBC will have impaired liver function. And it's impaired liver function that is relevant here. In fact, most people with PBC will have absolutely normal liver function and will be absolutely fine with most medications. So really it's the liver function which is relevant. And I guess the advice to this individual, if they're listening, is that they'll need to go back to their clinician, either the GP or the hepatologist, because those clinicians will have access to all of the information. They'll know whether the liver function is impaired or not. If it's not impaired, no problem. But if it is impaired, then they may need to rethink the prescription. Okay.
Thank you. So we've got an interesting one. The next question, being diagnosed with PBC and taken Urso. On 3 occasions, I have had a strange sensation in the inside of my arms, traveling to the top of my back and shoulders. It comes on suddenly and it makes me feel as though I'm going to pass out. Could you please let me know if this is part of having part of the symptom of PBC? Can I just say to everyone out there, anybody with a new symptom, go to your doctor. because it may not be PBC, but we do get other things. Anything new? I mean, I remember you were talking about bowels, diarrhea, excess tiredness. All of a sudden, you're really, really tired, much more. Go and see your GP, really run some tests. So what would you say to this person about this sensation?
Well, I'd say, I'd repeat what you've just said, Collette, actually, for exactly the reasons you're suggesting. If it's something which is completely new, then yes, it could be related to PBC, because in medicine you can never say things aren't related. You can only say that things are related. But other thoughts, other considerations need to be made. I mean, in a more general sense, I've not heard of people having altered sensation from PBC, so I think that would be unexpected. There is a mechanism by which people could be prone to fainting with PBC. People with PBC can have severe fatigue, as you know, and people with severe fatigue can sometimes have autonomic dysfunction. Your autonomic nervous system is the part of the nervous system which helps to control things like your pulse rate and your blood pressure and temperature regulation and so on. So if you've got autonomic dysfunction, then controlling your blood pressure won't be quite as good, for example, when you stand up, and you might then be prone to fainting. But that's a little bit of a stretch. So I think in this particular case, the person will really need to go to their GP and just go through those symptoms in a bit more detail to try and tease it out.
Thank you. When a new medication is approved by NICE or the SMC, for example, Ellibranor, how long before doctors can actually prescribe it for patients?
Well, it's not usually very long, but I mean, there is actually a legal position on this, which is that the drug has to be available via the NHS within 90 days.
Okay.
So that's the sort of strict forward answer to that.
Okay, that's quite quick. How does recurrent PBC present in the donor liver? Well, that's quite a lengthy question. That's, I think we
Well, I mean, we can go through. I mean, people may be interested, so we can certainly go through that. But so, I mean, usually it will be with bloods. The alkaline phosphatase, which is the sort of key blood test for PBC, will start drifting upwards. And that will be spotted quite early, because people who have transplants, for any reason, are monitored very closely. So that'll be an observation which is spotted at an early stage. However, there are many other causes of an elevated alkaline phosphatase after a liver transplant. So it sometimes takes a bit of time to finally say, okay, this is recurrent PBC, because you've got to work your way through all of those other potential causes first. So you'd want to check what the blood supply to the liver is like. You might want to check what the bile ducts look like. And you would probably end up needing to do a liver biopsy to be absolutely certain that this is recurrent PBC and not chronic rejection. So it can be quite a long period of investigations before you finally say it's recurrent PBC. Hopefully, the frequency of recurrent PBC is going down now, because we've started routinely giving ursodeoxycholic acid to everybody as soon as they've had their transplant. So basically, people don't stop the urso, and hopefully that will help to prevent or delay some of the recurrence.
Excellent, good. Can you have fibrosis without cirrhosis?
Well, you can, and the reason for that is that, in a sense, it's all semantics. Fibrosis refers to scarring of the liver, and cirrhosis also refers to scarring of the liver. It's simply that that cirrhosis refers to particularly severe scarring of the liver with a particular pattern of scarring inside the liver. So they, in a sense, mean the same thing, but cirrhosis means bad scarring.
Okay. If you have significant bile duct loss due to PBC, can these regenerate?
Well, yeah, I saw that question, and it's a very good question, but the answer is, as usual, there is no answer to it. The reason there isn't an answer is because we don't really these days do repeated liver biopsies.
Thankfully.
And thankfully, yeah, I mean, quite rightly. And the only way that you could really prove that the bile ducts have come back is by having a liver biopsy before you give highly effective treatment, and then repeating that liver biopsy after you've given the highly effective treatment, having witnessed some improvement in the blood tests. And then you might be able to see, okay, well, there was significant duct loss in the first biopsy and there's very little duct loss in the second biopsy. Therefore, we assume that the bile ducts must have regenerated. Even then, you wouldn't be 100% certain because there can be some sampling error from biopsies. So I don't know is the answer, because those sorts of things aren't done. They're not done in clinical practice and they're not really done in research either. However, we do know that the liver tests improve with good treatment. And we do know that very often people need second line treatment, for example, because they have significant duct loss. So I think we can probably assume that if people have gone on to second line treatment because they had very bad liver tests, and now the liver tests look fantastic, perhaps they've even returned to normal, I think there we could probably assume that there has been some recovery in the bile ducts. As well as the inflammation settling down. But the answer is I don't know for absolutely certain. Yeah.
Okay. So we finished the questions on the paper. I've now got them coming in online.
Good.
So I haven't read them before either. So we'll do our best. If the ALP is normal, but the gamma GT, cholesterol, HDL, IDL, and blood pressure all raised with strong positive for AMA, FibroScan 287 CAP and 7.8 kPa, and very severe fatigue, unable to work with some itching and nausea present, what other tests are needed to rule PBC in or out? Now, there's only, I'll let you answer.
If Kate is still online, then hopefully perhaps she wouldn't mind just sort of adding to that. Is this question because the diagnosis has not yet been confirmed?
Yeah, that's how it's looking to me.
Yeah. So I mean, this is it's an important question actually. The current guidelines, really, all of them, EASL, ASLD, UK, all suggest that you should make a diagnosis of PBC on the basis of anti-mitochondrial antibody being positive and alkaline phosphatase.
Yeah.
The alkaline phosphatase is the test to interpret. And the reason for that is because the gamma GT, although it also tells us about the flow of bile through the liver, is a notoriously sensitive test. It goes up with just about everything. It can go up as a result of atherosclerosis, hardening of the arteries. It can go up with fatty liver disease, and so on. It can go up with drinking. It can go up with certain drugs, etc., etc. So it's a very bad marker on its own.
Yeah.
Its main use really is to tell you what the alkaline phosphatase is coming from.
Yeah.
Therefore, the current UK guidelines suggest that actually you mustn't use the gamma GT to diagnose PBC. No. That said, there have been some studies in the last couple of years where people have had AMA positive, normal alkaline phosphatase, may have had an elevated gamma GT, and they've gone on to have liver biopsies, and the biopsies do actually show PBC. So it might be that we need to rethink this rule on the gamma GT, and that if everything else looks and smells and sounds like PBC, that we actually accept the gamma GT as being evidence. But that's not in guidelines just yet. So if there is a strong suspicion that Kate has PBC on the basis of elevated cholesterol and gamma GT and so on and so forth, then the only way to prove it would be to do a liver biopsy. And I guess that's the discussion to be had. Now, I'm not sure, would I have a liver biopsy just to prove that I have PBC? Probably not, because what is the practical advantage of that? The reason we have to make a diagnosis of PBC when the alkaline phosphatase is raised is because you can infer that there's a degree of bile duct damage happening in that patient's liver, and they need to start the treatment. if the alkaline phosphatase is normal, then the amount of damage in the liver is pretty slight, if there is any. And you could probably hang on. You can probably delay the treatment a little bit longer. So is the biopsy really going to change anything for the individual? Probably not, but I think that's when it becomes very individualistic, and I think that's when Kate and her own clinician will need to have a conversation about that.
Okay. So the next one. You know, the older I get, the more difficult I have to read. Right. Due to an inadequate response to urso, I've been advised to start Ellibranor, and I've been approved. Still waiting for funding to be agreed. What's the current situation around this?
Well, that doesn't really make any sense, because Ellibranor it's been licensed in the UK, and it's gone through NICE. NICE have approved it, and I presume the Scottish equivalent. Collette, you may know better than me, but I presume.
I actually don't. I'm seeing Dr. Bathgate in a couple of weeks. I'll ask him. I've seen him for 6 months. Yeah.
And once it's gone through NICE approval, then strictly speaking, the hospital should be able to.
Whoever this is, maybe you want me to give me a wee ring, and I'll find out what I can beforehand. But that doesn't make sense. That funding, if they say it's been approved, it's been approved.
It might be that for whatever reason, this person's hospital has not quite managed to get all their ducks in a row so that they can actually prescribe it. But strictly speaking, the NHS is now able to prescribe Ellibranor.
Yeah. So, well, give me a wee ring, whoever that person is, next week, and let's see what we can do. And then you asked a question. The lady has said, yes, she's under investigation. What was the question? That was. Yeah.
It was just to know what stage in the process the person is at. So I mean, the simple answer is the only way to prove PBC is biopsy. But we don't do biopsies lightly. We like to know that there's really good reasons to do so. Yeah.
In my day, and I've been diagnosed 32 years now. It was biopsy, but apparently I've never had a biopsy, but I'm the first in the UK. Apparently, I was told 2 years ago to be diagnosed without a biopsy.
Yeah, well, there you go.
There you go.
She was spared. I mean, we don't rush into biopsies. They're a perfectly routine investigation. There's no need for anybody to be worried about having one. But we, at the same time, we don't sort of rush into doing them.
No, and don't be afraid to chat it over with your doctor. They're not gods like they were 30 years ago. Chat it through with them, the pros and the cons and whys and the wherefores, and go away and have a think about it. Give us a wee ring, chat it through with somebody. It's more helpful, I think. Don't feel you have to have something done. You can always get a second opinion, to which you're legally entitled to. So right, we've got another question here. What is your thoughts on triple therapy, George? Already on urso, OCA, and waiting to be put on Ellibranor. Has any trials been done for triple therapy?
I mean, most hospitals that provide a second line treatment will have some patients on triple therapy. Admittedly, most hospitals will not be using triple therapy with Ellibranor because Ellibranor is so new, but there will be plenty of patients who are taking triple therapy with ursodeoxycholic acid, obeticholic acid, and a fibrate, bezafibrate or fenofibrate. And it does help. I suppose most people we should all be most worried about whether it's tolerated and whether it's safe. So the first thing is, yes, it does appear to be tolerated and safe. And then the next question that we should ask is, does it work? Well, it does appear to work based on the liver tests. And there are publications available on triple therapy indicating that the bloods do improve with it.
Okay. I've got another question, and I can't pronounce this, George. And can I take, and it's PROCH LORPERAZINE, tablets.
That's the procloroparine. So I think this is the same question that was on
the one with the vertical. Yeah, I don't know why that's come back in again,
yeah.
because I think
so. I mean, the answer I think is probably, but it needs to be chatted over with the GP or another clinician who has access to all of this person's blood tests.
Yeah, I think this is where I'm sorry, my dog walker's just thrown the dogs back in the door. I think this is where, what I was saying earlier when we opened up the session, that George or any of the doctors can't give individual advice, because you might be taking 7 or 8 other various types of medication, have other conditions, and a yes no is really not appropriate in questions like this. Would you agree, George?
Yeah. Although I suppose the sort of more general comment which might be useful to listeners is to know that actually the issue is not the PBC, the issue is the liver function.
Yeah.
And therefore, if the liver function is fine, we can usually work that out based on blood tests and scans, then that patient will be able to take most medications.
Yeah, sure. I think that's the end of our questions. But I think just while we're here, George, it's worth, for me, a couple of things which I say quite a lot down the helpline. I'd like your input. I think 2 of the most underused professions in this country are pharmacists and physiotherapists. My physiotherapist is married to a doctor, and she says doctors save lives, physiotherapists make it worthwhile. Sorry. I'm looking after my son's dog. Oh, this is a live show, folks. Yeah. People with aches and pains, maybe diagnosed arthritis, or whatever kind of things you get as you're growing older. I mean, I'm a great fan of physiotherapists, and I just think sometimes people are very quick to go to a bottle of paracetamol or what have you. And I'm a big fan of movement as medicine, as you well know, for fatigue. I just would like your thoughts, George.
Yeah, I agree completely, actually. I think we do underutilize physiotherapists and pharmacists. So I probably can't comment quite as well as you on physio, except to say, actually, that at a recent summit, was it All Volunteers Conference of the PBC Foundation, it might have been the beginning of this year or the end of last year, it was attended by academic physiotherapists doing research, who were doing particularly focused on the role of physiotherapy, of activity in fatigue management. And they presented some really wonderful results showing just how effective their interventions had been for people with fatigue. So I hope that actually we'll engage physios more in the management of PBC and PBC-related fatigue in time. And as for pharmacists, I couldn't agree more. They have a wealth of knowledge, and they can answer a lot of questions. I mean, many of the questions here, for example, is it safe to take procloroparine? Actually, the pharmacist will know better than the doctor, because they will understand the liver function element, but they'll also know about all the potential interactions that you were referring to. And likewise, the other question, the question about the urso and diarrhea, and whether that could be related to the formulation. Again, the pharmacist would actually know even better than the doctor, because they're the ones who know which formulations people are taking.
Well, it was a pharmacist that actually raised it with James and I at a conference we did in Bristol, and he was in the audience and he had PBC, and he raised it himself instead about the coating.
Exactly. And those are all nuances that actually clinicians who prescribe the drugs, the doctors who prescribe the drugs, often forget those nuances, whereas the pharmacists are trained to know all about that.
Yeah, absolutely. Yeah. Well, we've come to the end of the session. I think that's the shortest one I've ever done. I'm just checking my emails to see if there's any more that's come in, and there hasn't. But George, is there anything you would like to add to today's session?
No, I think
your dogs next time, Collette.
Looks like it's probably a short session because of the summer holidays and so on.
Yeah, that's right.
So no, I can only say
everyone
has a great summer.
Yeah, absolutely. I mean, we're in the middle of the festival up here in Edinburgh. Are you coming up to Edinburgh at some point, George?
No, but that's tempting, given that I'm only a couple of hours away.
Lots of fun. We were due to go to the tattoo on Monday night, but we had the gales, so it was cancelled. It's almost never, I don't think it's ever been cancelled, but it was
Yeah.
cancelled, the military
Wow.
tattoo. And my chimney came off instead, but never
Oh my
mind.
goodness.
I know, I've just got the bill.
Hope you've managed to fix that.
Well, apparently it's going to be scaffolding and all this. Anyway, everybody, thank you very much. Jacqueline, thank you in the background. George, it's been lovely to catch up with you, but do try a wee trip up to Edinburgh. I'll buy you some supper. How about that?
Sounds great. Thanks, Collette.
Okay,
Thanks,
take
everybody.
care, everybody.
Bye now.
Thank you.
Bye-bye.
Bye. Bye.